The work of proactively managing the chronic conditions of our clients was really what was falling through the cracks. And we also found that our providers were just overburdened with the day-to-day work of primary care.
The challenges for providers in expanding the medical assistant role and the team in general is letting go. And physicians are trained in a culture and an environment in which everything rolls up to them and everything is ultimately on their shoulders.
You need administrative support and you need a clearly identified, constant leader administratively.
We needed to have a long-term relationship with a few people in a team model. And that team model is with a primary care provider that's the leader of the team and clinically the leader of the team.
We first started the care team model with one care team in 2007. And on that care team we had a few MAs working with some providers, and we had an LPN who was working as a panel manager. And what we realized over the years is that we needed more clerical support in the team room. So we added a health assistant role, which is kind of a jack of all trades in the care team. We also have medical assistants on our care teams, and so historically they've worked as close clinical partners to the providers.
I just want you all to be sensitive to that as a team.
We developed our role of our team in an effective way in order to be able to support the upper level clinical, messy human relationships between office visits, all that stuff that goes along with what we really want our nurses to do. We needed to support it with an optimized team.
So like a patient. It became clear in visiting all the LEAP sites that primary care teams are complex organizations, and essentially they consist of a core team that is generally built around a single provider or a small group of providers.
How do we use the team? How do we document it? That's all stuff that's going to make or break this as a concept.
The core teams are surrounded by an extended care team that often is really seeing selected patients by warm handoff or referral. And in the LEAP sites, the major members of extended care teams were pharmacists, behavioral health specialists, and then laypersons playing important roles other than medical assistant kind of roles, like health coaches or community health workers.
Having added the health assistants to each team, it's like each addition that's made afterward, the whole team says, like, how did we ever function without that role?